Good morning, everyone. Welcome to this session on health equity and the pulse oximetry paradox. Our speaker today is Dr. Meghan Lane Fall. As I read Dr. Lane Fall's CV, I had to go over so many different things, so I'm going to share with you many of her accomplishments, but those of you that know her know there are a lot more. So, undergraduate, UC Berkeley, medical school, Yale, University of Pennsylvania for residency and fellowship in anesthesia and critical care, a master's in health policy research, UPenn. Dr. Lane Fall is currently Associate Professor of Anesthesia and Critical Care with an effective professorship happening July 2024. Congratulations, Dr. Lane Fall. She's Vice Chair of DEI at the University of Pennsylvania, Department of Anesthesiology. Her passion as a physician scientist has been research around implementation science and human factors engineering, along with many other things. She is Executive Director of the Penn Implementation Science Center at the Leonard Davis Institute. She is focused on patient and clinician safety. She's a Vice President for the Anesthesia Patient Safety Foundation. Her work in health equity has included work with UPenn, Blue Cross Blue Shield, a major insurance company, making sure that we're doing everything right around equity. Dr. Lane Fall's CV has at least 35 pages or more. She has at least 170 publications around many topics related to her work and her passion in critical care. Please welcome Dr. Lane Fall.
All right, good morning, everyone. Can you hear me okay? Excellent. I'm delighted to be here with you. I'm glad you came out. We have a perfect position. There's coffee nearby, so glad to see you all. As Patty mentioned, my name is Meghan Lane Fall. I'm on the faculty at the University of Pennsylvania. I'm delighted to partner with Medtronic to give this talk. It's actually the first such talk I've ever given. Patty's been trying to get me to give a talk for a long time. And she said, oh, but what about race and pulse oximetry? And I said, okay, that's the one. I'll do that one, because that's really important. So by way of disclosures, I spend about 80% of my professional effort doing research. And so that research is funded by the NIH, AHRQ, PCORI, American Heart Association, and Independence Blue Cross. That funding all goes to the University of Pennsylvania. I have some industry relationships, clearly this one with Medtronic. I also do some educational consulting for Janssen Pharma. And then I'm on the board of directors of the Anesthesia Patient Safety Foundation and the Foundation for Anesthesia Education and Research. I will say with my APSF hat on, we partner with industry because, how many of you are anesthesiologists? All right, you know that the toys and the gadgets and the widgets that we use, they're designed by industry. And so the APSF, which is the oldest national patient safety group in the country, has always partnered with industry because we know that they create the technology that we need to take care of patients. So there's never been a super strict firewall, but we do have to be open about the relationships that we have, which hopefully we are here. So I have some objectives for the time that we have this morning. I want to summarize the evidence that demonstrates that there are differences in pulse oximetry between different racial groups, and I want to help you understand why those differences are there and how we deal with them. I want to explain some of the patient and the clinical factors that are associated with differences in how the pulse oximeter works, and then I want to give you some practical recommendations because we're ICU people, right? So it's one thing to know about it in theory, but you need to know when you walk out of that door, what does it mean for you? And when you go back to work, how are you going to change your practice based on what you know now? I'm going to talk about how the pulse oximeter works. We're going to go back to the books. We're going back to waveforms. It's going to be a lot of fun. I'm going to tell you when it might not be trustworthy. I'll share with you what I was told in training, which was wrong. I was real salty when I found out about that. I'm not going to talk about manufacturer differences in pulse oximetry and accuracy. So even though this is sponsored by Medtronic, I'm not going to give you any brand names or tell you that this brand does better than that brand, okay? So I've been using a pulse oximeter since I was a medical student. I started in medical school in 2002, 22 years ago. I was told that the pulse oximeter would never read falsely high. I was told that you could put it anywhere on the body, and as long as you got a waveform, you were good to go. And then we found out, maybe not. So, you know that feeling when this thing that's so simple, that's so trustworthy, that's so wonderful, you find out it's actually not as perfect as you thought it was. So I just want to acknowledge that feeling, and my hope is that once you walk out of this room, you'll feel a little bit better about that. So let's go back and talk about how the pulse oximeter works. How many trainees do we have in the room? Excellent. So on your boards, on your exams, you may get some of these questions. You know, in preparation for this talk, I went back and learned about how the pulse oximeter was actually developed. So it actually comes out of aviation. And early work on the oximeter was meant to help World War II pilots detect hypoxemia, critical hypoxemia. Because the idea is that if you're up in the sky, you don't want to be hypoxemic because then you'll fall out of the sky. So that was the reason that they wanted to work on it, right? There was a Japanese scientist named Takuo Aoyagi who studied that work. He was a part of that work. He was inspired by that work. And he was dealing with these variations in light absorption. So they're working on the pulse oximeter and they're like, the signal keeps going in and out. What is that? It's a pain in the neck. And he goes, wait, that's arterial pulsation. We can do something with that. So that's actually the genesis of the pulse oximeter. And what you're seeing here is a picture of Dr. Aoyagi, also with John Severinghouse, who's an anesthesiologist who's done a lot of the basic science work to help us understand the conditions under which the pulse oximeter works or doesn't. So one of the big takeaways for you is that the pulse oximeter is a proxy for arterial blood saturation. So I told you I was going to tell you all the things I learned that were wrong, and I remember being told that the pulse oximeter would never read falsely high. I remember being in cases in the OR or in the ICU where you would look at the pulse ox and you would get a blood gas and there would be a different sat. And what I was told was, we don't know why this is, just pick the higher number, pick the one you like and go forward. Has anyone else ever been told that? It's rough, right? No one said to me that the pulse oximeter is a proxy. So the source of truth is the ABG. And that's one of the things I want you to take away. The source of truth is the ABG. So when we're thinking about pulse oximeter accuracy, you're looking at comparing the O2 saturation in the pulse ox, the SpO2, to the arterial oxygen saturation that's measured by a co-oximeter with a blood sample. That's the SaO2. And when we're thinking about accuracy, what manufacturers need to do, what they need to demonstrate to the Food and Drug Administration is specifications for ranges 70 to 80, 80 to 90, and 90 to 100%. And you'll see that the sensor type has different performance. And so that's another thing I want you to take away, and I'm going to reinforce. There are different types of sensors for the pulse oximeter, and they're calibrated for different parts of the body. You cannot take a finger probe and put it on an ear and trust that number. It's another thing we did all the time in the OR. Oh, it's not working on the finger, just clip it somewhere. I've clipped it on the side of somebody's face. I've clipped it on a tongue. I've clipped it like just anywhere you can get a number, just clip it there, right? On the forehead, anywhere. That's not okay, and I'll show you why. So going back to brass tacks, pulse oximetry is measuring the percentage, or it's a proxy for the percentage of functional hemoglobin that's bound with oxygen. You'll remember that within the blood vessels, the amount of oxygen that you have is the amount of oxygen that's dissolved in the blood and the amount of oxygen that's bound to red blood cells. Now, if you're an anesthesia person, you're going to be tested on oxygen content, where it'll ask you about the partial pressure of oxygen. But we know as clinicians that that's actually clinically functionally insignificant. The oxygen that's actually usable is what's bound to red blood cells. And so that's what we care about with the SpO2 and the SaO2. What are the fundamentals of pulse oximetry and how does it work? So there are a couple of different types of pulse oximeters. There are transmitting pulse oximeters and reflectance pulse oximeters. Most of us are used to the transmitting type, where you have an emitter and you have a detector. So we're showing our finger. This is the one we're most familiar with. So you've got light going from the emitter being picked up by the detector. The light's diffusing through the tissue, and the detector is picking up the difference in light. You may also remember that that pulse oximeter is transmitting two different wavelengths of light. There's red light at 660 nanometers and infrared at 940 nanometers. And the reason that we're transmitting, or that it's transmitting two different wavelengths of light, is that that light is absorbed differently by oxy and deoxyhemoglobin. And so you're taking advantage of the different absorption curves of those two forms of hemoglobin to tell you what the oxygen saturation is. So again, oxygenated and deoxygenated hemoglobin absorb light differently in the visible and the near infrared regions. So this is the absorption curve for oxyhemoglobin. you'll see its absorption is higher in the near infrared. This is deoxyhemoglobin. Its absorption is higher in red. And so this is our SAT. Two different curves that we're taking advantage of, and if you have any exams coming up, it may ask you, it's really kind of cruel to ask you for the numbers, but these are the numbers at 660 and 940. The second key principle is that there's variation in that light absorption that's related to pulsation. So as the light is going from the transmitter to the detector, it's going through tissue. And so that light is going to get dispersed, lost. Essentially, you can think of the light being lost. There's going to be some baseline light absorption that's related to the sensor itself, bone, tendon, and tissue, and then venous blood. All of us know that venous hum, right? So the venous blood is not pulsatile. All of that is noise. What we're interested in is that pulsation. And it's that difference in systole and diastole, that cycling blood, those changes in signals that the pulse oximeter is detecting. And that's how we derive the SAT. So the way that the pulse oximeter derives the SAT is using a calibration curve. And so at high saturations, remember that oxyhemoglobin absorbs higher in the near infrared. So at high saturations, that you're going to see a different profile of your signal amplitude, or the ratio of red to infrared, than you will for low saturation. And all of that is related to a calibration curve. So you get this R number that's red modulation over infrared modulation, and you can relate that to the SAT. So this is just, it's a calibration curve, it's built into the technology, but this is how it's coming up with a number. It's measuring the changes in pulsation, and it's relating that to a previously derived calibration curve. And that has everything to do with the sensor itself and where it's supposed to go. And this is one of the reasons that you can't just move the sensor from a finger to an ear and expect it to be accurate, because all of the assumptions that are built into the technology to give you this calibration curve don't apply to different parts of the body. So you really have to be careful about using the right sensor for the right part of the body. Even if you can get a number, remember the assumptions are not being met, so you can't trust that number. So the way the pulse oximeter works is it's measuring the pulse, it's determining the absorption ratio, and then it's using that calibration curve to give you a SAT. So again, here are the fundamentals. These are the really important pieces. The arterial blood volume changes during the cardiac cycle, and that gives you this periodic variation. This is the reason that pulsation is so important. So on all of your seats, you'll see there's a card from Medtronic that's there online, sort of learning about pulse oximetry, but there's also an 8.5 by 11 sheet of paper that's a summary of a recent paper published by Philip Bickler in his lab at UCSF. It just came out in like December. And it talks about differences in skin tone and the performance of the pulse oximeter, but it also talks about differences in perfusion and the performance of the pulse oximeter. And what's really important to take away is that perfusion influences the accuracy of the pulse oximeter. And it has everything to do with the fact that the pulse oximeter has to detect these changes in pulsation. So if your perfusion is poor, the pulsations will be dampened, the pulse oximeter is not going to work. Unfortunately, there's an interaction between skin tone and perfusion such that people who have darkly pigmented skin tone suffer from that even more, and we'll talk about that. But this first principle, that the pulse oximeter is leveraging those changes in arterial pulsation, is really, really important. So if you have challenges with perfusion, your pulse oximeter will be less reliable. Second key concept, oxygenated and deoxygenated hemoglobin are absorbing light differently at these different wavelengths. And the third point is that the SAT that you get, that lovely number that you get, is from a calibration curve that's unique to the sensor. It's unique to the part of the body that the pulse oximeter is placed. So these are some of the key takeaways. So I've sort of alluded to some of the things that might influence how the pulse oximeter works and whether it's accurate. Again, the pulse oximeter is a proxy for the blood gas. And so you have to ask yourself, when can I trust it? And when am I less trusting of the pulse ox? When do I need to look for confirmatory information? I think it's useful to divide it up into patient factors and clinical factors. So as you break it down, if you think about patient factors, one of the key things, anything that affects pulsation. So poor perfusion, as we talked about, or if you have venous pulsations for some reason, motion. So if the patient has a tremor, and a lot of us have seen this, if the patient has a tremor, that may interfere with the pulse oximeter signal and with the accuracy. Any pigments. So we're going to talk about skin pigmentation, but that also means nail polish. And what I was told as an anesthesia resident is blue is the worst. I don't know if that's true. I should ask my partners back there if that's true, but any pigmentation can affect it. Henna dye can also affect it as well. There's a couple of interesting papers that show that if your fingertips have henna on them, that it might perform differently. Skin pigment we'll talk about. I will signpost that race is a proxy for skin tone. It's a very poor proxy, and we will talk about that. But some of the research that's come out that's related race to the accuracy of the pulse oximeter is using race as a proxy for skin tone. We all know about abnormal and dysfunctional hemoglobins and that affecting the performance of the pulse oximeter, and then also anemia, so just how many blood cells you have. External factors, anything that affects pulsation, so if you're defibrillating someone, if they're on ECMO, if they're getting PT on the bed that's shaking, all of that can affect the pulse oximeter. Pigments, again, so it can be patient pigment or it can be the pigments that we give. So intravascular dyes, methylene blue is a fun one in the ICU. Ambient light can affect the performance of the pulse oximeter. I've said this a few times and I'll hammer it home. If you are not using the sensor the way it's supposed to be used or in the place that it's supposed to be used, that will affect the performance of the pulse oximeter. And if you're putting it on a place, forehead, I got my friend over here, right? There are forehead pulse oximeters, but if you're applying a finger, like one of those things that's meant to wrap around the finger and you stick it on the forehead, that's a no-go. So let's talk about skin pigmentation, because this was, one of the reasons that we're here is to talk about this. So let's talk about race. Why are we talking about race? Skin pigmentation correlates somewhat with race. The more we mix as groups, the less good a proxy this is. And so I just want to say, when we're talking about race in this context, it's because race is related somewhat to skin pigmentation. So dark skin pigmentation can impede pulse oximeter accuracy. This is something that's been known since the 1980s. There's another thing I never learned about in training. As an anesthesiologist, we use these things all the time. I would think, they asked me about the vapor pressure of desflurane, but they never told me that the pulse oximeter wouldn't work as well if you were darkly pigmented. Now, I think one of the reasons that this wasn't a prominent part of training is that the thought was that it only applied at oxygen saturations that were already so low that you would have intervened anyway. So the thought was, this is really only an issue when your SAT's below 80%. And if your SAT's below 80%, you're going to do something anyway, so why does it matter? What we have learned is that this can actually operate at higher oxygen saturations, and it probably has to do with that relationship between skin pigmentation, or that interaction between skin pigmentation and perfusion. So we are actually seeing these differences at clinically relevant, high, sort of acceptable, in quotes, SpO2 ranges. So we know that patients who are in groups that have darker skin pigmentation are more likely to have inaccurate readings. So the recent conversation around equity and pulse oximetry really started with this letter that was published by Schoeding and colleagues out of the University of Michigan that demonstrated a higher rate of occult hypoxemia in patients who were identified as Black in medical records. How many of you have ever done medical records research? It's dirty. Those data are dirty. The EMR is not great, right? And if you've ever looked at the race in the EMR and the race of your patient, sometimes it's right, sometimes it's wrong. It's really messy data. But to the extent that they were mostly good at identifying patients who were Black and patients who were white, leaving out a whole bunch of people in the middle, by the way, in terms of skin pigmentation, they saw that there was a higher rate of occult hypoxemia. What is occult hypoxemia? It's when your SpO2 is reading higher than your SaO2. So they saw more of a split in patients who were self-identified as Black in the medical records. And why does that matter? If we make decisions, clinical decisions, based on the SAT, on the pulse ox, then that means that those clinical decisions are more likely to be inappropriate for patients in those groups with darker skin pigmentation. This was especially important for COVID because there were SpO2 cutoffs in many institutions that would determine whether you got admitted to the hospital, whether you were administered oxygen, whether you were intubated, whether you went to the ICU. So if you can imagine that you came into the hospital and the SAT of 90 was your cutoff, which it was in many places, because we were all overwhelmed, we didn't have enough space for everybody, and we had to make some decisions. So if you imagine that the SAT cutoff was 90, and if you're 90 when you go home, and if you're 90 you stay, guess what? We were sending home darkly pigmented patients who were actually hypoxemic, and some of them went home to die. So that's why this is important. And so there was an understandable, hubbub, furor about what do we do now? So is race a thing? We talked a little bit about race and skin pigmentation. Race is absolutely a thing, but it's a social thing. And I do think it's important for us to be mindful of where race as a social construct is important in the care of our patients. It's important in how we talk to them, how we engage with families, how we arrange for ancillary services, post-ICU discharge, conversations about end of life, advanced care planning. Race is absolutely important. What we're talking about here is the technical performance of a device. It's hard for me to see how the social construct fits in there. So really what we're talking about is skin pigmentation. But certainly as we look at equity at a population level, we want to make sure that groups of people have equitable outcomes. And so there is an interaction here, but for the pulse oximeter in particular, there's a technical issue that relates race, which is a proxy for skin pigmentation, to performance. And so I really want you to anchor on the skin pigmentation piece of it. That's what we're really focused on here. We know that race is correlated with ancestry, but it's not a biologically coherent concept. So I'm not going to talk a lot about race, although I'm happy to in the Q&A. Many groups, including some groups at my institution, are focused on pulling race out of clinical algorithms because it is a biologically incoherent category. So they're pulling it out of EGFR, out of PFTs, out of maternal health algorithms. But again, for pulse oximetry, the conversation has more to do with skin pigmentation than anything else. So let's talk about skin pigmentation. Race is a bad proxy, so there are actually ways to characterize skin pigmentation. And so as we've seen research explode in this area, which is really good after that Schoeding paper, people have been trying to characterize skin pigmentation in a more precise way than this person's black, this person's Asian, this person's white. And there are some subjective ways to do it. So there's the Fitzpatrick scale, there's the Massey-Martin skin scale, there's the Van Lucien's chromatic scale. It's a start, right? There's a dose-dependent relationship between the level of skin pigmentation and the accuracy of the pulse oximeter. So the darker you are, and the reason this is because melanin changes the absorption of light. And so those calibration curves were not accounting for melanin, right? So some of those assumptions are not being met. But that's the relationship, is that melanin is a pigment. And I told you, any pigments will affect the performance of the pulse oximeter. Whether it's henna, whether it's nail polish, whether it's methylene blue, or whether it's melanin, will affect the performance of the pulse oximeter. So here's a start, or subjective tools. Increasingly, we're seeing people use objective tools, which are awesome. So spectrophotometers, colorimetry, melanosome volume fraction seems very interesting. I'd see it's still very early days to figure out how to reliably characterize skin pigmentation and to figure out how that influences the performance of the pulse oximeter. And manufacturers are on top of this. Industry partners, they've been thinking about this and figuring out how to adjust and adapt because they want their devices to perform well. And I'll say I've talked to a number of different companies. Without exception, this is an important topic to them. They want their devices to be reliable, trustable. They're working on this. I will say, as I think about the measurement of skin pigmentation, I look at myself and I'm like, well, I'm one color here and I'm a different color here and I'm a different color in other spots. So we'll see. But there are at least people working on trying to more precisely characterize skin pigmentation so that we can then figure out how to adjust the way that we measure the pulse ox and use it as a proxy for oxygenation. As I mentioned before, the differences in performance associated with skin pigmentation, the differences in pulse oximeter performance are not new. This stems back to the 1980s. And the relationship, the reason that this is an issue is that deoxyhemoglobin and melanin are the primary light absorbers in the skin at the wavelength used for hemoglobin absorbance. So again, it's the concentration of melanin that is associated with this performance issue. Now, I mentioned on your chairs you have a summary of the Bickler study. I'd encourage you to look up the study itself primarily. It's published in Anesthesia and Analgesia. This is a lovely infographic visual abstract that was created by the journal to summarize the differences in performance of the pulse oximeter. So what they did was a prospective study, which is great, right? Because some of the studies that we've seen were all retrospective, secondary data with all of its issues, all of the messiness of those variables. So they did prospective data looking at 146 healthy individuals. I say it to the ICU audience who deals with patients who are not healthy, but it's a start, right? And they looked at varying levels of skin pigmentation. They looked at sex, because in some studies, sex has been associated with the performance of the pulse oximeter. They looked at the perfusion index, and they looked at age. What they found was an association with skin pigmentation, which is not surprising, we've known about this, but also the perfusion index. And I've hammered home that the pulse oximeter, the way it works is by picking up changes in pulsatility. So if your perfusion is poor, the pulse oximeter will not work as well. They did not find that pulse oximeter performance was associated with sex or age. And so some of those studies that have shown differences in sex and performance of the pulse oximeter were probably confounded by anemia or perfusion or other factors. You'll see in the lower part that the bias related to perfusion is worse for people that have dark skin. And so you'll see, again, this dose-dependent relationship that in the presence of hypoperfusion, you'll see a bias that increases as skin pigment increases, as people's skin gets darker. And so this is a really important thing. I've given you a lot of takeaways, but this interaction between perfusion and skin pigmentation is a really, really key one. And when we're thinking about inequities and disparities in care, it's adding up all of these factors together that then give us some of the patterns that we see in terms of inequities in care and outcomes. So you want to think about the technology itself, you want to think about the sensors that you're picking and where they go, patient perfusion, and then skin pigment. So where do we go from here? I've given you a lot of reasons to be concerned about the performance of the pulse oximeter. Should we stop using the pulse oximeter? The answer is no. It's a life-saving device. We don't, I think back on when I was in training, we always had the pulse oximeter, but I remember the stories from the attendings who said, yeah, we just kind of used to look to see if they were turning blue, or if they were black, their lips got a little darker, or we'd look in the surgical field and the blood didn't look as bright as it did before. And I'm like, let's not go back there, okay? So I don't think the answer is to get rid of the pulse oximeter, but the answer is to know when to trust it, when to validate, and hopefully we'll see some industry and some technology fixes as well. But it's sort of a yes and, both and approach to dealing with the pulse oximeter. So I've already been a little bit of a buzzkill, but it's really easy to misuse the pulse oximeter, and we really have to resist the temptation to abuse the pulse oximeter. We all deal with patients who have a difficult to get signal. Maybe they're vasculopaths, maybe they're on 3 pressors, maybe they don't have fingertips. So we know that this is difficult. So I want to raise your hand if anyone's seen someone put the pulse oximeter finger clip on an ear. Right. Or the finger adhesive probe on the forehead. Got my friend over there, I've definitely seen that. This is a problem because the pulse oximeter and those calibration curves are making assumptions about the light path length, right? Because I told you that absorption of the light, some of that is just the tissue itself, and then some of that is the arterial pulsations. And if it's making assumptions about the path length for a finger is very different than the path length for an ear. So it's not valid to take the sensor that's meant for one part of the body, put it on another. Another thing, it kills me, even if you get a strong plethysmograph, your pulse oximeter can be wrong because of those calibration curves. So even if you put the pulse ox on a part of the body where that probe wasn't meant to go, you see that lovely waveform and you're like, yeah, I got my waveform, it's good, I can trust it. You can't necessarily trust it, even with a strong waveform. And I was telling one of our partners, a few of them actually last night, I took care of a patient in the ICU at the end of the year last year, so a few weeks ago, who was this lovely black woman who'd had a surgical procedure, had altered mental status, and ended up in my ICU. Came up to us on room air. SAT was 96, I think 97, totally unresponsive. Sternal rub, nothing. I said, let's get a blood gas. Her PaO2 was in the 40s. I said, put oxygen on her. And we put oxygen on her, and she said, hi. I was like, oh, God, this is bad. This is bad. So we have to, and her waveform was lovely, by the way. So we have to be vigilant. We have to pay attention to these things. There is some data to support that if you put the pulse oximeter in the wrong place, you will get the wrong number. You can overestimate saturation. So again, the pulse oximeter can give you a falsely high signal. But we know that improper placement is poor. So as you walk out of here, I want you to be evangelists for the idea. Don't just put it wherever you can get it. Don't put it, I've seen people put it on the ear and then like tape it to keep it in place, right? If you're having to tape it, that's a signal it's probably not meant to go there. And we've got to figure out another way to measure oxygen. I also want to reinforce that you need to use a holistic approach to the patient when you're thinking about hypoxemia. The pulse ox is one number, just like the CVP. How many of you make a clinical decision based on a CVP by itself? Don't raise your hand. Right? It's a piece of information. The trends are useful, but I am struggling to think of a situation where I will make a clinical decision based on just the CVP. Similarly, you should not make a clinical decision just based on a SAT. Think about all the other manifestations of hypoxemia. Mentation, the woman I told you about earlier, altered mental status. Respiratory rate. Do they look like they're struggling to breathe? Do they look like they're struggling to get enough oxygen in there? Look at their skin color. Are they darkly pigmented? Maybe you will have a lower threshold to get an ABG or some other confirmation of their oxygenation. Maybe they look dyspneic. Maybe they're having chest pain. Think about all the manifestations of hypoxemia, and if someone is acting hypoxemic with a normal pulse ox, you still need to rule out hypoxemia. One of the things that we've done at the University of Pennsylvania is up-adjust our SpO2 goal range. So this is work that was led by Christopher Chesley, who's one of the pulmonary intensivists at Penn. We were setting out to replicate the Schoeding work, so across a couple of our hospitals, across a range of manufacturers, we said, do we see occult hypoxemia in patients who self-identify as Black? So again, problematic definition, but it's a proxy. And we saw the same thing. Many other groups have published the same thing. But we then went the next step and we said, okay, if we up-adjust our goal SpO2 range to 94 to 98% for people without lung disease, do we see a decrement in occult hypoxemia? And the answer was yes. And so now in our ORs, in our ICUs, on our wards, when you order oxygen, the default is 94 to 98%. We didn't see an association with an increase in hyperoxemia, right? We worry about hyperoxemia as well because there's challenges with that. So 94 to 98% for us was sort of a sweet spot. I will be clear, this is a stopgap, right? We need the technology to be different, but as a stopgap, you might want to shoot for somewhat higher SpO2 ranges, especially in patients who have dark skin tone. So as I'm wrapping up my conclusions, the pulse oximeter is very, very powerful. So I don't want you to walk out and say, I'm done with the pulse oximeter, everyone gets a blood gas, because we can't do that, right? We're not going to put art lines in everybody. We're not going to A-stick everybody. We can't do that every moment, right? Every minute you get a new blood gas, that's not going to work. So it is a useful tool. We need to continue to use it, but we need to understand what its limitations are. The source of truth is the SaO2, not the SpO2. If you have hypoxemic conditions, the accuracy is worse. So I would worry more about this if my SAT is 90 or 88 than I worry about it at 99%. And we have to be vigilant for those clinical signs of hypoxemia. So don't treat the pulse oximeter number alone. You have to use these properly, so don't move the sensors. And then I would say especially use care if you're making a disposition decision based on the pulse ox. And I think it's incumbent upon us to look at all of our policies and procedures, and where we do have these cutoffs where we say, we'll send you home if your SAT's above 90, we'll send you out of the ICU if your SAT's above 92, we have to really look at those numbers because they may not function for everybody in the same way. So I'm not sure what the answer is. We have to figure that out at our own institutions, but those cutoffs are probably going to serve us poorly, especially for patients who have darker skin pigmentation or who may have problems with perfusion until we have a technology fix. So that's it for the prepared comments. We have plenty of time for questions, and thank you so much for your attention.